All right. Good morning. And thanks everyone for braving the blizzard that has just started to be here. It was pretty pronounced as I was coming down the hill. I said there wasn't a blizzard when I was just right there. So thanks for being here. This is really an exciting day for Rainbow and our quality program as we celebrate the annual Ann Pinkerton Rainey lecture in quality and safety and excellence in pediatric care. Um, you know, I was fortunate enough to know Anne. She was a force, not only in our community here in Cleveland, but especially at UH. She was a longtime director of the board of CMC. She was also on the board of UH, the whole system. And I was fortunate enough to get to know her in the capacity as president of the Rainbow Babies and Children Foundation. And she was president at the time when Rainbow was at a very critical juncture in their patient safety journey. And she was so supportive of all of the work that we were doing and really helped the board understand, patient quality, patient safety, patient experience, and was all about it. And so she was able to lead the board to understand what it was we were doing and why we so desperately needed their support. Um, I just, we're so thankful to the Pinkerton Rainey family who has supported this lecture because it allows us each year to bring in somebody who is so renowned in patient safety and quality and be able to share those ideas with our community. So it's really an honor to be able to thank Anne and her family for this gift. And we will have Dr. Charles Macias, who is our chair of quality for the entire system here at Rainbow, introduce our speaker. Charles?
Thanks, Claudia. So I too wanted to thank the Pinkerton Rainey families for their support of this endowed lecture series in honor of Ann Pinkerton Rainey. We're fortunate really to have the opportunity to honor her relentless drive for the highest quality and safety achievable for the families we serve within the Rainbow system of care. I also wanted to thank them for joining us in person today as we launch Patient Safety Week a few days early. Patient Safety Week is an annual global event aimed at raising awareness about patient safety issues and promoting practices to reduce or prevent medical errors and improve patient outcomes. We're fortunate to have Frank Federico joining us today to present today's Pinkerton Rainey lecture. Frank is a pharmacist by training and a world-renowned expert in patient safety. He was an executive high reliability coach affiliated as the former vice president at the Institute for Healthcare Improvement, focused on helping organizations and teams improve patient safety, quality, and the application of high reliability principles in healthcare. He served as core faculty for the IHI Patient Safety Executive Development Program and has co-authored the framework for safe, reliable, and effective care. He has been the senior lead for efforts to improve patient safety in the U.S., England, Portugal, Qatar, Brazil, and Wales. Please join me in welcoming Frank Federico.
Good morning, everyone. Thank you for being here, and those of you who are virtual, thank you for joining us today. Thank you for that introduction. Let me just start with just a story. A patient who went to the emergency room, and I know this is an adult example, was complaining of severe pain in her leg. They suspected it was a blood clot. However, it took some time to get the CT scan and to get her to surgery. Patient lost part of her leg. With that, let me say thank you and do some housework here just to make sure we do all the right things to continue education. The disclosure said I have no financial interest in anything, but I am on the Laerdal subcommittee for patient safety. So if I mention simulation, I am not pushing Laerdal because we can do low tech simulation. We don't have to have the big tech. So I want to be clear about that. but I continue to be faculty for the Institute for Healthcare Improvement. And if I mention IHI products, which I will, they're free to download. Please go to the website and take them down. There's no monetary requirement there, nothing. I likewise want to thank the family of Ann because we had a great dinner last night together. And the legacy of continuing and making sure that we're improving the quality of care as well as patient experience, something that was really important for Ann, are examples of what we need to be doing constantly. Because we need to put our patients always first, and we need to make sure we have quality. And that becomes important as I talk about where we're going to go and how we get better. Our objectives here, we're going to talk about why I think we have plateaued in patient safety and how that fits into your experience. So I want to congratulate you because you are part of the Solutions for Patient Safety, SPS, and you've been doing some great work there, which is great. I know some of the people who started that work, Steve Rudin, the Cincinnati Children's and others, and it was just fantastic that you are at that point. However, even with the Solutions for Patient Safety, there's still more to be done. And so Joyce and Dr. Mathias, thank you so much for when we talked and prepared and just going through this. It was a wonderful opportunity to say, let's try out what I'm thinking and see how that fits with what you're doing. If you take nothing else from this session, just take that unless we have a clear vision of what it is we're trying to accomplish, and unless we have that bold goal, more than just what we might be doing now, we're not going to get better. So it starts with a vision, and that's where leaders come in. We have to. Great. Thank you. Okay, I'm glad. The other piece is that we need to engage staff. They know how to do the work, and I know you are doing this, and it's important, but we need to find better ways and more engagement of staff. But we also need to understand why is it that staff is not able to do what we expect to be done. And we have to engage the patients and families. And in pediatrics, especially, my background is I was director of pharmacy at Children's Hospital in Boston. And we learned very quickly that if mom tells you something doesn't look right, pay attention to it because mom knows best. So how do we engage patients and families? In this case, you have two patients. You have the parents and you have the child. And that's how important it is to do that. And also, how do we build the right environment? And by that, I mean, we call it psychological safety. We call it a culture of safety. Call it whatever you want. But what is that environment that allows people to speak up, to stop the line, and also fully appreciating that in healthcare, we just can't stop working. Unlike the airline industry, where if a pilot says, I'm really tired today, I don't think I want to fly, the pilot is excused. Well, we were talking about this last night at dinner. How many of you can say that and be excused and say, well, the patient can wait? No, that's not going to happen. So we have a different challenge in healthcare. We mentioned the framework for safe and reliable care and the introduction. This was built with many years of experience at the Institute for Healthcare Improvement, and it is a compilation of all the experience of our faculty, the participants of the program, the Patient Safety Executive Development Program. And we chose these elements, these three elements that are critical that we believe, whether you are on an HRO journey or you just want to improve quality, leadership is so important. And when we talk about leaders, we talk about leaders at every level. So it is the board, it is the C-suite, it is the managers, it is the supervisors, but it's also the people who don't have titles, but are leaders. These are people who are well respected. And gee, if Donna does this, I'm going to do it too. If Joyce does this, I'm going to do it too. Now, sometimes that leadership might be not what you want, but these are leaders and you have to care for that. The other component is culture. And by culture, we're not changing your local culture. We're not changing the culture of Cleveland or Ohio. We're changing the culture in the workplace. And I'm going to talk about what it takes to start changing that culture because it's all about behaviors and what do we do there. And of course, do we have a learning system? And this is where I think we got stuck. And I am one of those people that went out into the world and say, standardization, simplification, you do these things and it's going to happen. And we said, address central line infections and everything will be better. Well, we still are fighting central line infections. We're still fighting pressure injuries. We're still fighting falls. There's so much more to be done. But foundational to all of this, and none of this will happen unless you develop trust. And that trust has to be between the staff, amongst themselves, with leaders, and leaders have to trust the staff. because the staff know what's going on. They're the ones that can tell you what needs to be fixed. And they can sometimes tell you what to do to fix it. And leaders have to be open to that. But at the same time, we have to trust our leaders if they're taking us in the right direction. Zero harm. Audacious goal? Is this one of your goals? Yeah. So people will say, we'll never get to zero. That's true. I don't think we'll ever get to zero because we're humans. We're working with other humans. We're in a very complex system and it's hard to achieve. But it's a goal. It's the North Star that we want to go to. So I flew here yesterday on American Airlines, and we know there've been a couple of incidents with American Airlines. But would I fly any airline that says, you know, it's okay if we have 2 to 3 accidents a year? That's okay. Right? So how many of your patients and families would say, well, let's go to Rainbow. They only have like a few central line infections. And what does that mean for patients? I really want you to stop and reflect a little bit. What do we tell our patients? We have great hand hygiene. I don't care. I don't even know what that means. Isn't that what you're supposed to be doing anyway? And yet we say that's how we might attract patients to our system. And I know you have competitors here. So what's going to help you become unique? What's going to help you draw people to your hospital? I like Vince Lombardi. I'm a football fan. By the way, I'm sorry, the Patriots are the Patriots and, you know, they're history now. But in any case, what he said is, we will chase perfection and we will chase it relentlessly, fully knowing that all the while we can never attain it. But in the pursuit, maybe we'll catch excellence. And that's why zero harm is a goal. We're never going to get there, but in trying to get there, we're always going to get better. So how good are you? How do you judge yourself? I have a little bit of a problem with serious reportable events because there are not many of them. There should not be many of them. And usually they're just the tip of the iceberg because there's something that there's been major systems problems. But how many other little other problems are existing every day that yet haven't become a major system problem? But if we fix them, maybe we'll prevent the serious reportable event. And I know we did a study at the Institute for Healthcare Improvement using our global trigger tool, and we identified more harms than any other way of identifying harms. Whether it was incident reports, whether it was chart reviews, it was just, we found a tremendous amount of harm. So if you think of a patient's experience, is it only the central line infection you're worried about? Or is it the other things that you wouldn't want to happen to your child if they came to this hospital? We look at harm reduction. We look at close calls or near misses. By the way, close calls is not a right word, or maybe it is. People use near miss. Well, near miss means we hit. We nearly missed it, but we got it. And it actually comes from the Army, where when they dropped bombs, they said, well, we nearly missed the target, but the bomb had a significant effect on everything else around it. Instead, maybe it's that we had a really serious event here, or we had something that could have become a serious event. But I'm going to challenge you, just as I challenge the quality committee that I'm on at a Boston hospital. I don't want to hear just about how many times we've prevented harm or how many times we've had an event and then investigated it. I want to hear how many times have we actually achieved what we were intending to achieve? How many times do we get the outcome that was expected? Because that to me is what I'd be interested in. I want to know, did you deliver the right care? Did you deliver it in a way that was safe, effective, timely, the dimensions of quality, that my child is doing better? My child can go back to school. My child is living a more fulfilled life. All of those things are important. So you could have the safest hospital in the world, but that doesn't mean you're the best, because maybe you're not delivering on your targets. One of the things that I think got us into trouble is we identified what are the dimensions of quality, and then we took safety out and we started working on safety. And then, oh, by the way, there's an equity group. And oh, by the way, there's a group looking on efficiency. And we created these silos of work. And they each became their own little turf. And excuse me for saying this, but for those of you who are patient safety, well, we're patient safety, you're quality, you manage quality. No, they're all one thing. And you have to treat patient safety a little bit differently, just like you have to treat some of the equity differently, because they're different things you need to do. But ultimately, if they're not folded back in together, what are we doing? Are we helping ourselves? And having this discussion with Don Berwick, if you don't know the name, Don Berwick is the founder of the Institute for Healthcare Improvement. He, again, pushed forward and saying, why did we take it apart? Now, I will tell you that maybe there is a small reason. As a pharmacist, when I was back at Children's in Boston, in February, we used to have Poison Prevention Week. So we do all these things to teach people about poison prevention. And when Mary and I had our first child and Paul started crawling around, we said, we have to make the house safe. So we did all the poison prevention things that needed to be done. But anytime we went shopping, we didn't come home and run a safety event. We blended what we did into our shopping. So we knew we wouldn't buy something that had a cap that wasn't a safety cap. We knew we weren't going to buy something that was going to be harmful to him if he got into it. And if we did, it automatically went to a safe place. So we took that safety out, but then we blended it back into everything that we do every day. And that's what I'm pushing forward for us to be doing. Metrics. Oh, metrics. How many of you are wonderful and just ready to go out there and start measuring stuff? Everybody ready? How many metrics do you have? What are you really looking at? So if you haven't put anything in your library, Joyce, Tyranny of metrics and what matters. Measure what matters. By the way, you are an improvement advisor, so I'm sorry if I say something that you don't like about measurement, but not many friends are my friends are improvement advisors. But I believe that there is a place for measurement. But sometimes we overmeasure. And sometimes the measure becomes the target. And that's when we get into trouble. In my work, I was able to go to England, and I don't know if you have this, but there was a requirement that the NHS, the National Health Service, made of every hospital in England. No patient should be in the emergency room without getting care more than 4 hours. The intention was fantastic. The downside of it was that if you did not have a good rate of people being served and getting successful treatment, you would be penalized. And penalized was you wouldn't get funding. So hospitals worked really hard to make sure that their patients got out of the emergency room. And we visited one hospital that actually had received an award for getting those patients out of the emergency room. They had the best in the country. And I said, great. So we started going around the hospital as we usually do. And I visited the cath lab and I found 4 patients in beds in the cath lab. And I said, what are these patients doing here? Oh, well, they were in the emergency room, but we had to get them out. So we put them in the cath lab. It's not a patient care area. And then we went out to the bay where the emergency room, the ambulances come in, and there were ambulances there, and there were patients in the ambulance. And how come they're not coming in? Well, we don't have any room, but the clock doesn't start ticking until we bring them in. So the goal there was not really to figure out how do we improve flow in the emergency room so we can see the patients we need to see. It was, let's rig the numbers, let's play games. Let's figure out, because Don Berwick has a great slide where at 3 hours and 59 minutes, there's activity. Okay, Joyce, move this patient. Quick, put him somewhere. And they might wind up off service. And you know, the term off service. So you've got a cardiac patient on a ward that's not a cardiac ward. And not that the nurses aren't good, but that's not their specialty. So now you have that different kind of a problem. We use measures incorrectly because if you're trying to improve, you don't need a whole ton of measures. All you need is just a small amount to know, is it working or not working? If you are doing research, you then need tons of measurement. And if you're comparing someone, you need to compare apples to apples. So you need to have the right amount of data and the correct data to be able to do that. But in measurement, what I find especially is the quality assurance becomes the only thing we do. It's necessary. I'm not saying don't do quality assurance, but quality assurance, unless you then act on your findings, doesn't become anything other than just we spent some time measuring things. But more importantly, what about if we actually chose measures and find out who are they important for? What do people really want to know? And that comes to what Don Berwick says is, why don't we ask the patient what they want to know? There's a wonderful hospital just outside of Boston And they have, as you walk into the emergency room, big chart that says number of falls, number of pressure ulcers, and now they've included staff harm. And I think it's great. Now, for somebody like me, I like to see that because that's the work I do. But does that matter to a patient? I don't know. Maybe, maybe not. Maybe we should ask them what really matters to them. But not everything that you do counts. Sometimes you can't count everything, and sometimes you think because you counted, that helps. But I'll give you an example. My son needed some testing, and we could have gone to a Boston hospital, but it was crowded. It was going to take some time. There was a hospital north of Boston that could do the same testing. And this hospital is built on a hill. So the buildings are sort of stepwise. I dropped my son off. They took him in for testing. I said, I'm going to go get a cup of coffee. Cafeteria is way down. So I went down to the last building, the cafeteria. Now I needed to get back up. I couldn't find my way. I get lost very easily. I get lost in my own town. I've lived there for 35 years and I still don't know where all the streets are. And my kids say, Dad, you travel all over the world and you come home. Something's good. What's going on? But anyway, I couldn't find my way back to the testing place. And as I was walking around trying to find a spot, one of the people from environmental services said, you look lost. I said, I am. I need to get back to the testing area. Now, he could have said, take the elevators, go here, take a right here. He said, let me walk you there. And he walked me. I said, wow, what a culture this place is. I mean, these people really care for families, for patients. Then I went back to Children's. And as you know, Children's is very busy, 325 beds, major pediatric hospital like you guys, or big hospital. And I just stopped in the lobby to see what was going on. And a woman came in and she had her baby in the carriage and she had a young toddler who was walking alongside and he's screaming and yelling. She's looking for the elevators and everybody who walked by, either their nose was in their phones or they were talking to someone else and no one stopped to say to this woman, can we help you? And I said, what a difference in culture. Not that the people at Children's are bad, but nobody stopped to say, we're here for the patients. Why aren't we doing what's right for the patients? That patient that when you go into the room, you give that child a smile. Maybe you touch their hand. Maybe you look at that mother or dad who's really frustrated, who's worried about their child. You give them an encouraging word. Those things are never measured, but those are the things that really count. So think about all the things you could possibly be doing, not just because you have to count them, but because they're the right thing to do. The biggest problem I think we have in safety is that it's a moving target. So when we started with safety, we were looking and focusing primarily on errors. That is, what are the errors that are causing the harm? The medical malpractice study was all about that. And then it became like, wait a second, but patients experience other things. So if a patient gets an infection, maybe that's a harm that we should be counting. Maybe if a patient falls, that's something we should be counting. And so IHI was at the leading edge of saying, it's not just about errors, it's about the patient experience. So the target started getting bigger and bigger and bigger. And we keep adding to it because now we're saying you can't have safety without equity. Well, that's a harm then if we're not thinking about the equitable part of it. And it made it bigger and bigger. But we thought we were doing some good work. There was a study that came out in 22 that said, yeah, we made improvements. We made improvements in some areas, which is good. We've been working at this for a long time. If we haven't made improvements, then something else is wrong. But then the following year, David Bates came out with a study and says, no, at the hospitals we looked at, the rate of harm was about where it was when we did the initial study. So are things getting better? Yes or no? And to make things even more complicated, we use so many different instruments to measure success that we can't compare. We can't learn from each other. We use different definitions. So how do we learn? How do we learn which hospital is doing really well? And I'm going to talk a little bit about what it means to be a learning organization. And I think we need to come to grips with how do we measure that. I took this from Tom Nolan. Tom Nolan was one of the founders of the Associates in Process Improvement. He's the author of the book that is the foundation for all the IA program that we have at IHI. And the model for improvement is at the core of that. And I know you use the model for improvement and the PDSA cycle, if that's what you're familiar with. And Tom said, in life, the things that we're supposed to be doing is prevent, detect, mitigate. Now, the prevention part is how do we build systems that prevent errors or defects from happening? And we focused a lot on that. But the reality is, even with all of that interest and all of that work that we put in those areas, we still have errors and we still have defects and we still have patients being harmed. So the next step is, how do we have a system that detects those defects or detects the errors so that we can intercept them? But even then, sometimes we miss that. So the next step really is, how do you mitigate them? How do you ensure that even if we make an error, that we can immediately address it so that the patient isn't harmed any more than that? Or if we see a defect, that we can immediately go and fix that defect before somebody gets harmed. That's part of the strategy. In healthcare, we're really good at detection and mitigation. Just think of how we treat people. And we were talking about this last night at dinner too. It's okay if you get diabetes because we can tell you have diabetes and then we can treat it. It's okay if you get hypertension because we know how to treat hypertension. And only recently have we gotten to the point of saying we need to be upstream to prevent the diabetes as much as we can, to prevent the hypertension as much as we can, because that's the better way of treating patients, not just waiting for them to get sick. So it's the same with our systems. We shouldn't just be waiting till we find a defect. We should always be looking and predicting, where can we fix things? What can we make better? Here are all the things we've pushed: policies, procedures, training. I mean, think of all of these things. These are all things that have been in place, and we've all been pushing to do them, and do them better. But that's where I think we've reached the plateau. Because even with doing all of these things, looking at Dr. Bates' study, just looking at your own work, boy, we thought we got rid of central line infections and we just had one. What's going on? So we continue to make errors, but we're not stopping to understand why that's happening. Why do we continue not to do the right thing? I think part of the problem is we've taken this solution to problems as being a linear type of approach, rather than understanding that healthcare is very complicated. There are so many moving parts in healthcare, and we've tried to simplify it. But trying to simplify it, I think we're fooling ourselves into thinking this is the best way to improve safety. It is one way to improve safety. I'm not saying don't do it, but I'm saying we need to do more. So let me give you an example of a discharge process. How many of you like roll your eyes and say, oh my God, discharging a kid from this hospital takes forever? How many different departments are involved? And by the way, this is from the NHS, because it's the only diagram I could find that was complete and had all these pieces. But all of these components all have to work in harmony for you to be able to discharge a patient. Whether they're pediatric or adults, all of them apply. But now take that and put on top of it all the requirements that come out from the Department of Public Health, the Joint Commission, any agency that's out there, and they further complicate the problem. So it makes it even more difficult to be able to do your job. And that puts a lot of pressure on you, puts a lot of pressure on your staff, puts a lot of pressure on the patient as well. I want to go home. What's going to get me home? So let's think a little bit differently. I think the first thing we need to do is to think about healthcare as a complex adaptive system. Yeah, it's a term. It's something, it's a buzzword. But what we mean is that there are so many moving parts, that the system is somewhat chaotic. And I'm sure all of you, whether you're a provider or you're a parent, you'll know. Last night we were talking a little bit about how complicated it is to try to get healthcare. So let's remember that as we think of making our systems better. We have poor design. We start things without really thinking ahead of time to say, how can we make sure that this system doesn't have defects? We just jump into it. And even when we make improvement, we just jump into the improvement without stopping and saying, what could go wrong that we have to anticipate? We have to look at behaviors, and how people behave is so important, because behaviors drive culture, but behaviors also drive actions, and actions sometimes have consequences. We must learn from what goes well as what does not go well. Most of the time, we're investigating, doing a root causes analysis on what went wrong. And by the way, I don't think we do root causes analysis well at all anywhere. We think we do. Other industries have been doing it for many, many years and have refined it, but we have done it once. That means we can do it all the time and do it well. Well, that's okay. But how about all the things that we do that are done well? Have we stopped to figure out why? At the IHI, we have a motto that says, steal shamelessly, but implement wisely. So what do I mean by steal shamelessly? Well, this ward is doing, or this unit is doing some really good work. Let's go see what they're doing. But then we stop and say, oh, what they did is they developed a checklist, they implemented the checklist, and it works. Well, it works for them. Because looking at what went well means many things. It should be, why were they successful in the first place? Oh, they've got a great manager or leader who really pushes them to get at the head of the class, to be the best. They've got a staff that's committed to wanting to do this work. They've got great teamwork. They've got the ability that if something's not going well, they can speak up. In my work in Wales, there were a number of presentations that we always pick and highlight somebody. And most of the people did the same thing that I said in the first place. Oh yeah, we took this list, we implemented this, we did that, and everything went well. Then one group got up and started explaining their journey. And I said, this group sounds like they were coached. And in fact, they were. The IA who was on my team coached them into the presentation, because what they were able to explain was the reason we were successful is we were brave enough to say, whatever system we had in place was terrible. Let's throw that out and start again. What we need is a leader who says it's okay to take this risk. Now, we're not setting this up to hurt patients, but sometimes you've got to try something, maybe in simulation. Maybe you just do it on paper. Let's just look and see, is this even a better way to do it? And that becomes an important aspect of what we do. We have to think that this isn't someone else's problem. Well, we do this, this is the way we do it all the time. This is the way they do it on that unit. But if you see something's not going well, it's your responsibility to speak up. It's your responsibility to say, why do we do it this way? Well, it's the way we've always done it. Isn't there a better way? So something that's happened that I notice around the world is the minute you come in and say, we're going to do some improvement, the staff immediately say, oh, what, did we do something wrong? Right? Well, sometimes improvement is because we did something wrong. But sometimes improvement is there's just a better way to do it. And we just don't do it that way because things change. Our patient population changes, our staff changes, requirements change, science changes, lots of things can change. Improvement doesn't mean bad. It just means we can find a better way to do it. And think about it that way. If you are on the HRO journey, remember things like preoccupation with failure, more buzzword. That means that no matter how well you design the system, there's opportunity for not going well. Sensitivity to operations. Think of those clowns who do those characters with the balloons. They fill them up with air and then they twist them in the whole bed. So think of one of those long balloons. If you squeeze it in the middle, that air has to go somewhere. So when I was at the Department of Pharmacy at Children's in Boston, if I decided to change something about how medications were delivered, that I stop and think, what does this mean for the nurses? What does it mean for others who may be impacted by the change I make? We weren't smart enough to do sensitivity to operations. We all did our own work in silos. And the most interesting part was when they changed work rounds for the doctors from the morning to the afternoon, they never told us that they did that because the largest number of staff members we had were on the day shift. And yet all the work was now coming on the evening shift and we couldn't figure out why is the evening shift getting overwhelmed? Why are nurses so frustrated? Well, it was because they changed it, but they never told us. We could have reorganized staff. We could have done other things if only we had known and thought of a system. And then we have to think about what's the culture? What's the environment under which people work? I'm going to take a vacation, and this is my idea of a vacation. I think when all of you look at this, some of you who might say, oh, my Frank likes to sit on the beach and read a book. And somebody might say, no, he likes to go snorkeling. Look at that water. And somebody might say, well, maybe he likes to climb mountains. He likes to hike, right? Every one of you have your own perception. Why is that important? Because when you say your vision of what you want to accomplish, do all of your people understand what that means and how they can contribute? Because just as some of you thought of sitting on the beach versus being snorkeling versus mountain climbing, all your staff will think that way. When I was at Children's and our chief operating officer said, we're going to have the best pediatric hospital in the world. How does that feel to you? If I were to say that to you, you're going to have the best pediatric hospital in the world. It's overwhelming. How do we do that? What are we supposed to be doing? So if I went back to my pharmacist and said, we're going to have the best pediatric hospital in the world, what do you think they'd say? What? But my job was to translate that so that my pharmacist knew, how did they contribute? The nurses, how did they contribute? The doctors, how did they contribute? The labs, everybody else has a way of contributing. So when you state your vision of saying to advance science of health and the art of compassion, do the people know what that means? Do they know what's expected of them to be able to achieve that? And I think that's a problem. Because if people say, oh, quality is, that's Joyce's and Dr. Macias' problem. That's not my problem. And that's the expectation that's set out, then it only becomes their problem. But if the expectation is we all have to contribute to that, that changes the game. And that's why I think we're stuck, is that we set expectations, we create quality departments, we create patient safety departments, and then we expect them to solve all the problems. No, they're just your guides. That's not their job, is to solve the problems. Your values, you have great values. I'm glad you have what, 5? When I was at Children's at one time, we had 12. I don't know how you remember 12 values. So I'm glad you have just a small number. But just think of each one of these values. And how do you behave in support of those values? I want you to reflect a little bit. Think of the behaviors that you have. Think of your values. And think of what you do and don't do. So when you say that one of your values is teamwork, and then you have somebody on a team who's really disruptive, what happens? Does somebody address that? Does somebody look at that behavior? Because if you don't manage that disruptive person, and purposely I'm not saying the doctor, because we always blame the doctors. It's never just the doctors, it's everybody. But if you don't manage that disruptive person, that behavior then sends a message that we're not really keen on teamwork. We just have that as one of our values. Our quality is job one. How many times have you heard that? But then they don't do anything to support the staff to make sure that quality becomes the #1 job. So reflect on which behaviors do you want to have that reflect your values, and which are the behaviors that you want to replace with something else. And what happens when people don't fit? When Dana-Farber Cancer Institute had their event where they had 2 patients receive 4-fold overdoses of chemotherapy, they went through a major overhaul. And one of the things that we noticed after 5 years of the work they did is their culture changed. And part of that culture change was the behaviors that they had and what did they expect to happen. And sustaining that culture, I remember speaking with Jim Conway, who at one time I reported to, but then he went over to Dana-Farber as the chief operating officer. I said, Jim, how do you sustain your culture and those behaviors? He said, well, when we hire people that fit our culture, or people that will enhance our culture. And our staff will not invite someone to apply for a job if they feel they don't fit here. When I was at IHI, we had this open complex that everybody had a little cubby to work in. And few of us who actually had offices, including Don Berwick, our CEO, shared their office with 6 other people. Nobody was ever alone. You always had somebody around you. And when people came in to interview and they saw that, there were people who said, I can't work here. It's okay. But we want people that are willing to work in this environment. That's part of what you do to sustain culture. So why all the focus on behaviors? Well, if you think about what makes a culture is made up of its food, its language, its artifacts. If I were to walk around your hospital, do I see quality boards? That's an artifact of your culture. that you're willing and transparently want to put up data so people can see what's going on. And behaviors are such a key element of that. So we push more and more to say, if you have the others, but you don't have the behaviors, you're not going to get better. Why don't people follow the rules? So there's a stop sign in my town at an intersection. And one day I just said, I'm going to see how many people actually stop. What do you do at a stop sign? You stop, right? Isn't that the rule? To be safe. That's why they put a stop sign there. I would say 3 out of 4 cars never really stopped. They did what's called the rolling stop. Now, the picture in the middle on the bottom is one I really love. It's a Volkswagen commercial. I don't own any stock in Volkswagen, or nor do I care. But it's a guy who's on his phone, paying attention to his phone, and he's crossing the street. And the Volkswagen is touting this new technology that says, we'll prevent you from getting into an accident. And sure enough, the car beeps or whatever it does and stops. And he looks at them and he says, what's wrong with you? I'm on my phone. Can't you see? Well, because he has no respect for what the rules are of crossing the road. But why does that happen? Well, sometimes we avoid something, or we want to go ahead and not stop at the sign because there's a perceived benefit. If I take this shortcut, if I don't stop, things are going to be okay. It's better for me. I need to get to work on time. Nobody's going to see me. So how many of your staff might take a shortcut and say, nobody's going to know I took the shortcut? It's inconvenient for me to do that. And you can go down the list. I don't understand the risk. If I choose not to use the barcode before I read the barcode on the medication, before I administer the medication, I don't think that's anything bad. Everybody else does it. Why don't I do it too? So all of these apply. And each one of those is because Rene Amalberti said, this is what life is really like, is that we have areas that we put in standards and rules and policies and all those things that we think people will always behave, that they'll always be part of. There's a space called the usual space of action, which is where people really are working every day. And then ultimately there's that illegal space where people are just breaking the rules and willfully because it's to their benefit and people really get hurt. But what happens in everyday life? Well, we have personal issues. We bring our own baggage to work. I remember one morning I showed up at work. My 2-year-old had been up most of the night and I probably looked really bad. And Jim Conway, who I already mentioned, looked across the table and he said, you look terrible. And I said, thanks, Jim. That's the way you greet me in the morning. And he said, yeah. I said, yeah, my 2-year-old was up all night and I was awake. I didn't sleep. And he said, well, at least you knew where he was. Wait till he's a teenager, then you're really worried. But the point here was I was in a leadership position and I had not had any sleep. So my judgment would have been very compromised that day. But imagine if I was caring for a patient. That's a problem, but we never take that into account. We look at things like the policies that we put in place, the requirements that we want people to do. Do we ever stop and say, how much of this work is actually work that's not necessary? How many checklists or assessments do you have? And you notice we put a lot of this stuff on nurses. Not that doctors don't get their share or others don't get their share, but a lot of the safety improvement stuff is for nurses. These are things you have to do. How many assessments do we ask them to do? How many times do we ask them to do things that in the long run? My mom walked into the hospital. She had very high blood pressure, walked into the hospital, and she walked in. She was fine. I bet if they did the assessments, she said she's not a fall risk, no cane. She did fine. They put her in the bed. They gave her furosemide to get off some of the fluid she had because she had congestive heart failure. And my mom said, I'm dizzy. All of a sudden, she's a fall risk. Now, if the nurses had done that falls assessment and spent the time, in 5 minutes, that falls assessment was wasted. Why don't we just treat everybody as a fall risk? Because they are, everybody is a fall risk. And for your children, we always worry about the kids falling out of beds, right? So we have systems and places to prevent them from falling. So we make things more troublesome. We put more labor into people's already busy lives. And then people make choices. Every day we make a choice. we decide that we're going to do something different, whether it's I'm going to drive a different way, I'm going to choose something off the menu, I'm going to choose not to do this action. But each time you make a choice, something is going to happen. And are you understanding the risk of what's going to happen? Can you predict, if I make this, what could go wrong? We don't take that into account when we're talking about patient safety. We don't stop and say, people may not use the checklist. People may not do the assessment the way we want them to do it. People may not insert the line exactly the way we want them to insert the line. But we don't stop and understand that. And I think that's one of the problems we have, is we don't think about humans being humans who are able to then make those choices. Adam Grant says, if you make a choice, can you predict what might go wrong? And if you can predict what might go wrong, do you know how to mitigate it? So yeah, I am going to administer this medication without reading the barcode, but I do know that what I'm giving them is Colace, so it's not a big problem. But no, I'm giving a dose of gentamicin, and have I checked that this is actually the right dose for this baby? If only people speak up. How many times do you know there's a problem, as I said, and you don't do anything about it? How many of you do walk-arounds? Any leaders in here who do walk-arounds? How many of you are recipients of walk-arounds where somebody comes to visit you? I think walk-arounds, when they were first introduced in healthcare, I mean, I think back that our first adverse drug event collaborative, Tom Nolan, who I mentioned earlier, was our improvement advisor. And Tom came to me once and he said, how many leaders do you think actually know how a medication is distributed in a hospital? Let's take a walk. And we did a walk around. We simulated a walk around. And we found that it was more complicated than we thought. And we said, which leaders are willing to do this? And then fortunately, my colleague, Alan Frankel, brought that to healthcare. Executive walk-arounds. And walk-arounds have advanced. It's not just showing up, but it's actually digging more deeply, building the culture, encouraging people, rewarding people in the sense of when you see something good happening, call it out. The ability to spread that's something good and saying, hey, I know you have a problem here. Have you looked at that ward across the way or that unit across the way? They're doing pretty good. Maybe you'd like to go visit them. And so when somebody does walk-arounds just to tick the box, they're not doing walk-arounds. But when you go and visit, the part of a leader is to say, what's the pebble in your shoe? And we shouldn't minimize any pebbles, because eventually, I like the analogy that match becomes a forest fire. When those little things are getting in your way and nobody's addressing them, they eventually lead up to something really bad happening. Now, we started this by saying, in measurement, what do we measure? For whom are the measures? But we also need to understand, what is it that patients want? So this is from the Josie King Foundation. And you guys may know Peter, who's your chief quality officer from there. And they came up with the 10 things that the foundation said parents and patients want. So reflect. Are these the same things you think patients want? Are these the same things that you already believe in and that you're supporting? Because I think it's so important for us to understand the work that we do. And why is that important? Last night we talked about this as well. We just put an electronic portal for people to look at whatever we give them, and they can always communicate. And you know what? A lot of patients really don't care. A lot of patients probably don't even use the portal. Now, we have a whole new generation of people coming up who probably will want that. Like my sons probably will want it. For me, it's so-so. But when they looked at what gave patients satisfaction, it wasn't things like electronic portals. It was about adding care coordinators. It was about peer shadow coaching. It was about better team communication, because the nurses were saying one thing, the doctors were saying another. And even amongst the doctors, they were saying different things. And ultimately, physician empathy. So let's really understand what our patients want, because that's going to be a component for us to provide and become the best hospital ever. What about staff? What do staff want? There's lots of things that staff want. Oh, we don't want to work so hard. No, that's not true. Staff come here to work, but they want to be doing work that's meaningful. But don't be frightened. by this book that said patients come second. And when I saw this, I have to read this book. I said, I got to see this. If you haven't seen it, read it. He's not saying that patients aren't important. What he's saying, though, is that if you really want to improve the quality of your care, you got to make sure you take care of the people who are going to be doing the work. You've got to make it better for them to do the work. Make it safer for them. Make it easier for them to do the work. Again, we come back to improvement. Improvement means we found a better way to do it. So you don't have to take all those steps that you used to take before. And everything we put in place. And by the way, how many policies do you have? And you ever looked whether or not the policies conflict with each other? I worked in an organization that every time they did a root causes analysis, they came up with a new policy. And you could go into their risk management room and they had shelves of policies. And they had no idea how many they had, and they had no idea whether they conflicted with each other. But we complicate things by doing things like that. So think of your staff. Think of what's important, because if they're in a good place, other things are going to get better too. A learning organization. I think this is key. Remember I said there was a patient who went to the emergency room and had to have part of her leg amputated. When they debriefed that, they spent more time debating whether or not this was a serious reportable event that should have been reported, or whether it was just, it's the best we could do, and we didn't do anything wrong. And when they decided we really couldn't predict whether or not she was going to lose her leg, they closed the book on the case. And when my colleague shared this with me, I said, what? First off, the nurse from the emergency room called to schedule the CT and said, we've got an emergency down here. We need to have a CT done on this person. She called 3 times because nobody responded. Finally, they get the patient up to CT and they say, we've got to do surgery. This is critical. They did their informed consent process with the patient, but she said, I'm not sure I want to have surgery. I want to talk to my family. They then had to find her family and explain to the family, which meant another several hours delay in the procedure. When they finally got in there, they saw how much damage had been done that they had to amputate. But they never saw that as an opportunity to learn that we don't have a good system. Because when I said, what's your door to balloon time? That's when somebody comes in with a heart attack. And they said, oh, we're the best in the area. We have the best time. And I said, so you can get a patient from the emergency room to the cath lab in no time, but you can't get a CT done in the amount of time that needs to be done. Why aren't you learning about that? And she said, that's exactly how I feel, but the people were more interested in whether or not this was a serious reportable event. And I remember at one of the Boston hospitals, I attended a chief's meeting, and the chief of surgery leaned over to me and he said, we spend more time debating preventable and non-preventable than we do in trying to fix the problem. So let's get beyond it. If a patient experienced it, a patient experienced it. We're not blaming people. We're just trying to figure out how to make it better. But in order to be a learning organization, there's a lot of things that you have to do. And here's just a graphic that displays that. But importantly, there has to be a commitment from the very top to say, everything that happens, we have to learn. But we have to learn why people make decisions. We have to learn why things don't go the way we expect them to go. Because sometimes a decision that's made in the boardroom or a decision that's made in the executive suite has a significant impact downstream. Do they even understand what's going on there? So we're not going to get safer until we understand the entire process and all the things that come along. We also have to think about accountability or responsibility. Depends on the definition that you accept. Accountability tends to have a very negative concept of we're holding you accountable, we're blaming you, as opposed to I have a responsibility to do what I'm supposed to do. But you also have a responsibility to look at your own behaviors, because you can't be blaming and saying, if only they did this, what are you doing about it? And if you see somebody who's not behaving properly, to create that environment that supports people, are you holding that person accountable? That does not mean that you berate someone. Sometimes it's what Jerry Hickson calls as a cup of coffee. Dr. Macias, can we just have a cup of coffee and let's talk about something? Because sometimes when you call it to their attention, they've realized, oh, is that what I'm doing? I never realized I do that. So how do you help others behave in the ways that are necessary? Again, that enabling environment. So the three takeaways: make sure you have a clear vision. What's your expectation? And do people know what's expected of them in order to achieve that? Are we listening to our staff and are we listening to our patients as to what's really important to provide quality care? And do we have that enabling environment in place? Because although we may have pieces of it, I don't think we have it all in place the way we should. So I've covered a lot of material, but I want to end with Avitas Dhanabedigan. Many consider him one of the leaders of quality improvement in healthcare. And in the end of his life, he experienced healthcare as a patient. And so he had a lot of reflections about what's going on. And he said systems are important, and understanding how systems work is very important. But if you don't love your patient, if you don't love your profession, and if you don't love your God or whatever other being or whatever you honor, you really won't get better at it. Because you really have to love what you do. You have to love the people you're caring for. And if you do that, you will then be able to go back and fix the systems because you'll have a different view of what's going on. I want to thank you for all your efforts. I know that you're on your journey. I know you have great leadership that's helping you on that journey. Congratulations. But I think we could do more. And I think we have to do more. So it's important for us to understand that and to say, do we know why people make certain choices? Because we have all these policies, we have all these standard work, and yet people still don't do it. Why is it that we don't stop at the stop sign? Because those little things are what wind up making things worse. But thank you for all you do. And some of you will never know the names of the patients that you impacted because maybe you're not in direct care. And last night we were talking about how this particular lecture series and how this family has impacted so many lives. They may never know who they are, but for all of them, thank you. Are there any questions? Please, I'd like a question. I'd like somebody to challenge me and say, oh, come on, Frank. Any questions?
Thank you very much. I really enjoyed it. The dreaded comment and a question. You mentioned early in your talk, hey, an airline pilot can tap out if they're tired, but a physician cannot. We are currently filling out our ACGME surveys for our trainees, and I need to be very explicit. We have very explicit policies about we need to be more like pilots. You need to recognize when you shouldn't be seeing patients and you can tap out. So that's just an editorial comment.
Great. Great.
There are a lot of toggle points in there. One of the catchphrases of my entire residency, and you learn these as a student and as an intern, what should I do? Do the right thing. And it was before there were so many policies and procedures, you couldn't just look it up on the internet. There was no internet. It was, your North Star was do the right thing. And I couldn't agree with you more that we now have an uncountable number of policies and procedures that get us most of the way there. I would argue that those policies and procedures are part of who's or what is watching when you don't stop at the stop sign. I think there is a value in, if it's important, we would have some guidance. It's not just accidental that everybody now has the exact same color, the exact same shape on their stop signs. What it means to stop in Cleveland is exactly what it means to stop in Boston because somebody made that a policy. So I'd love to hear more of your thoughts. It's an impossibly big question. Where is that transition point between the benefit of policies that we have a shared understanding of what this means and when we empower people to roll through the stop sign? Because it's a really snowy day, and if I come to a complete stop, it's going to be really hard to start again, and it's actually safer for me to do the rolling stop at the stop sign, for example.
Right. And understanding that is important. So let me just say, I'm not advocating throw out your policies. Not at all. I think I agree you need policies. However, we say policies and procedures, but we don't separate them. Policies are, we stand for this. So we stand for you stopping at the stop sign because it's a safe thing to do. However, contextually, what does that mean? Now, I always use the example, what do you use for two patient identifiers? name and date of birth. Well, what do you do in the NICU? Excuse me, baby, what's your name and date of birth? Or what do you do in the emergency room? Excuse me, you're unconscious, what's your name and date of birth? So the policy should always be, we do our best to make sure we have two identifiers so that we don't wind up with two patients with the same name and we get confused. But how we do it has to be contextualized. That's where the procedures come in. So the policy is, we're always going to do this, but how we do it is going to have to be based on the patients we're dealing with, the situation, the context. So policies are necessary, but remember, we have policies as a sledgehammer. Everything becomes a nail or a rock that we're going to crush. But sometimes they're not policies, they're guidelines. Sometimes they're algorithms. Sometimes we don't need to write a policy, we just need to offer some guidance. So that's another, we can get into a big discussion about that, because that work I did with that hospital, it was like half of these aren't policies. It's just that you have the clout to say, we have to write a new policy, but that doesn't solve the problem. So it's a great point. Thank you. Anybody else?
Thank you. Sort of following up on Michael's comment, I attend in a step-down neonatal intensive care unit, about 35 babies, a bunch going home each day. There's two sets of parents. There's the parents who are terrified to take their peri-me home and will do anything to stay. And then there's the parents who can't get out of here fast enough. And you can't treat them the same way based on the policy. And my criterion of failure as a 2-week attending slot is if a baby bounces back from home or from the NICU proper, that's sort of like maybe not the right criterion for failure. So it's a challenge.
Yep. So what matters to you as a patient? What matters to you as a parent? And the skill that you have is you can start picking out the patients who, or the parents who, they're a little anxious about this. How do we help them? How do we help them understand what it is they have to do? How do we provide support when they go home? I mean, there are different ways to do that, but you're absolutely right. Not everybody gets it the same way. You have to be able to contextualize it to the need of the patient. What does the patient really want? What does the family need and want? If it's their first baby, oh my goodness, they're going to be really frightened and the baby's sick. If it's their second or third, I have 3 boys, the youngest, poor kid, you're on your own, kid. Go do what you need to do. But you need to know that and listen to the parents. Because if they went home and, as you say, failure is readmission, then we're not delivering quality care. We're not doing what's right for the patient.
Follow that up with one comment. The young man sitting in front of me, Mr. Pinkerton, was a NICU patient in 1973. And this lecture would not be possible if that wouldn't have set his mom and has put him out on a path towards great leadership in this institution. So thank you.
Yep.
It is after 9 and we know that people have to go, but there's so much more that we want to talk with Mr. Frederico about. So please join us in the community room for a meet and greet. And I hope that everyone stays safe today when you leave in the blizzard that it looks like it is outside right now. Thanks for joining us.
Thank you all.